Hello, my name is Dr. Michael Wohlfeiler. I am the Chief Medical Officer for the U.S. At AIDS Healthcare Foundation. I've been asked to speak today regarding on the topic of protecting the continuum, HIV screening, testing, and linkage to care in the COVID-19 era. So what I'm going to be talking to you about is the issues that AHF encountered, how it impacted our care continuum, and how we responded to the issues created by COVID-19. I'm going to be speaking only about our domestic US program. My colleague, Dr. Penny Ayatone, will be discussing this topic from our global perspective. So just to start with, let me give you a little bit of background about AHF and tell you who we are. We're a US-based global public health nonprofit involved primarily in HIV care. We've been around for over 30 years. Our mission is to provide cutting-edge medicine and advocacy regardless of a patient's ability to pay. And at present, we are currently providing services for about 1.4 million people located in 45 countries. Our budget for 2020 is 1.7 billion US. I'm going to give you a brief overview of some of the relevant business lines in our and services in our domestic program. First of all is Department of Medicine, which is the department that I lead. We provide direct medical care through a network of healthcare centers. We're actually the largest provider of medical care for HIV positive persons in the United States. Currently, we have over 55,000 clients at our healthcare centers. The majority are HIV positive. Those who are HIV negative are often coming to our healthcare centers because they're at an increased risk for acquiring HIV. We have 68 healthcare centers located in 16 states plus Washington, D.C. and Puerto Rico. I want to touch on our public health division because that's the part of AHF that provides HIV testing and also STI testing, diagnosis, and treatment. The walk-in STI clinics are known as wellness centers, and we have 24 wellness centers located in 9 states plus the District of Columbia. PhD also operates 15 mobile testing units in 9 states, and those units go wherever the need is and whatever hours of the day are needed to capture the people who need testing. I also want to mention our pharmacy department because that's a critical component of AHF. We have 56 pharmacy outlets in 15 states, District of Columbia and Puerto Rico. The majority of them are co-located with a healthcare center. So it really creates a one-stop shopping for our patients where they can see their provider and also get their prescriptions filled at the same time. All of our pharmacists have to be certified as HIV experts by the American Academy of HIV Medicine. And then finally, I want to mention our out-of-the-closet stores. These are thrift stores, but most importantly, they are places where you can walk in and get free rapid HIV testing. And we have 20 OTCs located in 7 states. Just some miscellaneous facts about AHF to give you an idea of our size and our the scope of our work. In 2019, we performed almost 4.5 million free HIV tests. Globally, in the United States, we did 221,000 free HIV tests, and globally last year we distributed over 90 million condoms. So let's get into the care continuum. So the first step obviously is HIV testing. So our testing and linkage care services are provided by our public health division, which I've already mentioned. We make available walk-in rapid HIV tests at multiple sites, which I've already touched on. For patients who test positive at one of our HIV testing sites, they're immediately assigned a linkage counselor, who is also part of, linkage counselors are part of the public health division. And these linkage counselors immediately connect with the newly diagnosed patient to provide education and emotional support. They often will immediately arrange a face-to-face meeting with the client, and again, to provide that in-person support that somebody who's newly diagnosed may need. They also make sure that the patient gets an appointment with an AHF provider at one of our healthcare centers within 72 hours of the diagnosis. I can tell you that often the appointment occurs the same day as the test, or within 24 hours of the test. But our goal is that it has to be, cannot go beyond 72 hours. And the linkage counselor maintains close contact with the client through at least the first 2 clinic visits, and often will personally accompany the client to those first 2 visits. Moving on to the next step in the continuum, which is engagement in care. After that second provider visit, the linkage counselor will hand off the client to the Department of Medicine and the specific healthcare center that the patient is going to be seen at. And then at our healthcare centers, we offer a variety of services and resources. Obviously, we have skilled medical providers, physicians, nurse practitioners, and physician assistants. Most of our clinics include an RN who manages the clinical side of the office. And then we have other important staff positions. One of the most important is benefits counselors. They get involved when somebody is newly diagnosed with HIV and may not have a payer for their health care. Benefits counselors will determine whether the patient qualifies for Ryan White or Medicare or Medicaid or whatever is available, and will get the patient signed up for with that program. And then I want to mention a couple non-Department of Medicine services that are co-located with the healthcare, within the healthcare centers. I already mentioned the pharmacy services and what's known as the PIC, or pharmacist in charge, really serves as a member of the healthcare center team. We've tried to build a very close relationship. And then there are people known as pharmacy benefit specialists who make sure that the patient has some kind of coverage for their antiretroviral therapy. They'll get patients signed up for things like ADAP and other drug assistance programs. So I want to discuss some of the problems that we encountered as a result of COVID. The first thing that we had a problem with was, as did many people, is we didn't have adequate PPE to protect our staff. And because of that, we had to significantly decrease our in-person visits early on, and actually ended up canceling, this is early in the epidemic, canceled a number of scheduled routine follow-up visits. We developed a COVID-19 screener that every patient had to complete, that looked for signs, symptoms, or a history of possible exposure to COVID. If a patient answered yes to any of those questions, they were not allowed into the clinic, again, because we didn't have PPE that would protect our staff. We also initiated a daily PPE inventory reporting process and turned that into a centralized PPE report so that we knew exactly how much PPE and what type of PPE we had at every single one of our locations across the country. And then, of course, we also began an aggressive search for other sources of PPE. So another one of the issues that we encountered were, how we were going to handle planning, management, and coordination of our COVID-19 responses. We did not have a structure in place to do those things, and especially not for a response to a pandemic that was needed throughout our entire US-based organization. So the first thing that we did in response to that was we created a pandemic response planning executive committee that consisted of myself, senior vice president of AHF, 3 additional senior managers, and our global director of safety and security. And we had our first meeting on March 1st, and we met every day thereafter. You'll see in a later slide that eventually the duties of this executive committee were taken over by a different group, and the committee, this committee, really quit functioning. So we also encountered, early issues regarding infection control policies and procedures. A decision was made early on that Department of Medicine would be the entity responsible for developing all COVID related policies and procedures. The problem is that we really lacked initially the resources to do that. There was somebody who was a provider, or actually I should say a medical director of one of our clinics, who had the additional title of National Medical Director of Infectious Diseases, but her role in that capacity had been really limited to running a quarterly infection prevention and control committee meeting. Specifically, we lacked existing PMPs to deal with a pandemic, especially pandemic from a new and poorly understood pathogen. We lacked a management structure to handle a pandemic that was affecting the entire domestic operation of AHF. And other than our director of infectious diseases, we had no designated staff to assist in pandemic management. So in an attempt to respond to those issues and those deficiencies, the Department of Medicine created a COVID-19 clinical response team, or CRT. And it was decided that the CRT would be solely responsible for deciding and writing up and disseminating any COVID-19 related policies and procedures, not just for the Department of Medicine, but for all of AHF in the US. We also decided quickly that the CRT would be the only authoritative voice at AHF for COVID-19 information. We discovered very early that lots of people were, giving instructions and to staff and different guidelines, and it was just quickly becoming a mess. So we decided that there could only be one source of truth for COVID-related information, and that source of truth had to be the CRT. When we first started, the CRT only consisted of 4 people. It was myself, my deputy chief medical officer, the director of infectious diseases, and our chief nursing officer. Quickly, we realized we needed more people, and it ended up growing to include 10 people on the CRT. And honestly, we could have used more. These were all people who had other full-time jobs at AHF, but once they became part of the CRT, it essentially became their full-time job. There was so much work to do that they were allowed to completely give up their regular duties to work on the CRT. So what were the roles and responsibilities of the CRT? Well, first and foremost was the development of policies and procedures to deal with COVID-19. And the way we did this was every day the CRT would review any new guidelines issued by CDC or other entities, primarily World Health Organization. We would then discuss them as a team, prioritize them in terms of importance, and also assess our ability to implement them. We wrote up the PMPs and disseminated them by email using a standardized subject line, so that people would always know when a new guidance was coming out from the CRT. And the PMPs were all posted then on an internal website so that they could be accessed at any time by any AHF employee. The CRT also had to take on an education role and a monitoring role. There was a lot of training that needed to go along with the issuing of PMPs. And so we held multiple web-based training sessions for all domestic staff. Some of these were for all of the staff, then other meetings were specifically for the clinics, and so they were more medical in nature, and so we did different types of trainings for different groups. We also realized that we needed a way to monitor whether our infection control policies were being complied with. And so we created a new position of an infection prevention and control officer, and we appointed one IPCO at every AHF location, and told them that they had the responsibility to monitor and reinforce compliance with our COVID-19 policies and procedures. We also told them that if an employee was ignoring the IPCO's instructions and that the CRT needed to be notified, because we were going to strictly enforce our infection control policies. The other responsibility that the CRT had to take on was regarding employee infections and employee exposures. So we developed an electronic form that was available to anybody, and it was used to report both confirmed COVID-19 infections and possible exposures. Every form that was submitted was investigated by one or more of the CRT members, and they really did an amazing amount of in-depth investigation and did it very quickly, and then made a decision, disposition of the case. And that decision could be, that nothing was needed, or it could be isolation or quarantine at work, quarantine at home, et cetera. It also could be that other people at the work site needed to be quarantined as well, depending on likelihood of high risk exposure and so forth. We also said that the only group that could clear somebody to come back to work was the CRT, that it could not, person couldn't be cleared by their supervisor or anybody else. And the CRT kept a detailed log of every exposure that was reported, every infection that was reported, and what the resolution of that case was. So, I'm sure this holds true for most people who were involved in formulating COVID-19 responses. There were a lot of initial difficulties. A lot of it was related to the fact that there was a lot that we didn't know about this virus, and there was a lot that we didn't know about the pandemic, and how to protect what was needed to protect a person from exposure. The guidance from the CDC was changing rapidly. Sometimes it was changing on a daily basis, and it frankly got quite confusing. We also couldn't fully implement some of the CDC guidelines in the first couple months of the pandemic because we didn't have the PPE or other necessary supplies to do that. So let me talk about the impact that COVID-19 had on various steps in the care continuum. So first of all, with HIV testing and linkage to care, as I mentioned previously, in 2019, AHF conducted over 221,000 HIV tests in the US, and you can see that they were split. The tests were conducted across several different types of testing sites. If you look at the number of tests that were conducted in March of 2020 compared to March of 2019, there was about a 50% decline in the number of tests conducted by AHF in March of this year. If you look at a comparison between April of this year and April of last year, the number of tests conducted declined 98% from what they had been April a year ago. This shows you the numbers, comparing the number of tests in 2019 versus 2020, and you see that starting in March, there was a precipitous drop in HIV testing conducted by AHF. You can see that in May, it started to go back up, and it has gone up steadily, but we're still way below our 2019 testing levels. So what happened with our wellness centers, our STI and HIV testing and STI treatment centers? So there was a severe reduction in the number of patients seen at the AHF wellness centers. If you compare April of this year to April of last year, there was an 87% reduction in the number of clients seen. And so again, a severe impact on our wellness center visits, which is where about half of our HIV testing typically took place. This compares the wellness center visits in 2019 to 2020. And again, you see starting in March, a big drop in number of visits, you know, working its way back up a little bit, but still remaining well below our visit level for 2019. So what happened to HIV positivity rates during this time? Well, for the most part, they didn't change. I mean, obviously a lot smaller number of people were being diagnosed HIV positive at our sites because the number of tests was way down. Overall, the positivity rates didn't change much, except for this 1 month in April where there was a big spike in positivity rate. And we think that that's because in April of this year, the only people that were being allowed into the wellness centers were people who had active STI symptoms or had a confirmed positive STI test result. So we were seeing a very high risk group. We were seeing a limited number of patients, all of whom were at high risk for HIV infection, and that probably explains that spike in the positivity rate. So what impact did COVID have on our healthcare centers? Well, it wasn't actually that much of an impact. There was the biggest impact was that there was a big reduction in new patient visits, but there was only a mild and temporary reduction in established patient visits. What the biggest change that occurred in our healthcare centers was that prior to COVID, we really only had in-person visits. We had very little experience in telehealth, and that was limited to a small contracted telepsychiatry program that we had. So when we had to reduce the inpatient visits, because we initially lacked a telehealth platform, the initial shift was from in-person visits to primarily telephone visits, just audio visits. But we started to aggressively search out a compatible telehealth platform. We selected one, we rolled it out as rapidly as possible, and told the providers once they were trained to start converting all the telephone visits to true video telehealth visits. And so this looks at the impact on total visits to our healthcare centers between 2019 compared to 2020. And you can see that there was only a small decrease in April in the number of visits. And other than that, we've maintained the same level of visits at our healthcare centers. But what has changed is the types of visits. You can see that prior to March of this year, all of our visits were in-person visits. And then you see them shifting to a large number of phone visits. And now we're seeing an increase in the number of true telehealth video visits. We expect to see that trend continue with reduction in phone visits and increase in video telehealth visits. So now that we've got telehealth, even though we put it in place specifically for to deal with COVID-19, you know, what's going to happen to telehealth after we get through this pandemic? It's become clear to us that telehealth is here to stay and will need to remain a part of our approach to seeing patients. The acceptance by patients has been very good, and many patients want to continue to have the option of at least intermittently doing telehealth visits with their providers. One thing that we found that's interesting is that we've got a lower no-show rate associated with telehealth visits than we had for the in-person visits, and that's led us to believe that telehealth may actually help us with retention of patients in care. So I believe that is my last slide. Again, thank you for your attention, and I hope this has been of some benefit to see how at least one organization, what kind of impact COVID-19 has had, and how we have, and the steps that we took to try to minimize any negative impact from COVID-19. So thank you, and enjoy the rest of the conference. Bye.